Hey, good day, good morning, good evening, everyone. Thank you for joining us for the latest Targeted Neonatal Echo Foundation's curriculum seminar. My name is Danny Weiss. I'm a neonatologist at Sunnybrook in Toronto, and along with the NHRC education co-chair, Danielle Rios, we're pleased to bring you the seminar today. We're very excited to have two very esteemed guests in a topic of great debate, and that's the special format that we have today. Before we go on, I want to acknowledge the very kind support from Mallinckrodt Pharmaceuticals, who have provided a unrestricted educational grant for the Neonatal Hemodynamics and Targeted Neonatal Echo Foundation's curriculum. The topic today is the evaluation and management of patent ductus arteriosus, which anyone here today knows is extremely controversial. And we've set up a very special format today, which was a debate format with two very esteemed speakers. And I'll introduce them now. But just before I do want to mention that we have our panelists, which everyone in the seminar can see. And as a reminder, these are our trainees in neonatal hemodynamics and targeted neonatal echo. I would invite you to keep your camera off during the recorded portion, and we'll be inviting you back for the unrecorded Q&A. And for everyone, including those attending as seminar attendees, we would be very grateful if you could fill out the evaluations, which will be emailed to you after the seminar. So our speakers today are fantastic speakers, and the first who's going to be discussing why perhaps we should treat certain PDAs is Professor Afif EL-Khuffash. And he's a consultant neonatologist at the Rotunda Hospital in Dublin, Ireland, and a clinical professor of pediatrics at the Royal College of Surgeons in Ireland. His primary clinical and research area is the assessment of heart function in term and preterm neonates. And he's the lead for neonatal echo and heart function assessment in the NICU at the Rotunda Hospital. And he's assumed a leadership role at the European level in devising training guidelines for echo by the neonatologist. He's the lead author and editor of the NOTE project, which is a set of hemodynamic modules for trainees, which offering a new international online master's level education program in neonatal medicine with collaborations with a few institutions. And we're grateful that he'll be presenting the pro side, and the con side, or the potentially not treating PDA, is going to be presented by Dr. Bill Benitz. He's the Philip Sunshine Endowed Professor in Neonatology, an emeritus professor at Stanford University School of Medicine. And he served as Senior Associate Chief of Neonatology for clinical programs for many years, and as Chief of the Division of Neonatal and Developmental Medicine from 2007 to 2017. Dr. Bennett served as a member and chair of the American Board of Pediatrics, the subboard for neonatal perinatal medicine. He was a member of the AAP Committee on Drugs and served as a section on neonatal perinatal medicine, contributing member for numerous policy statements and practice guidelines. I think we all know his work on evidence assessment, decision analysis, and practice evaluation, including analyses related to early diagnosis and management and prevention of both neonatal infections and for evaluation and treatment for PDA. So I'd like to hand Dr. EL-Khuffash the floor, and the format is they'll be doing 15-minute seminars for their respective sides, followed by 5-minute rebuttals, and then we'll have the Q&A. Dr. EL-Khuffash and Dr. Benitz, we're grateful for your time today and very much looking forward to your presentations and the discussion. Thank you so much.
Hi, can you guys hear me?
Yes, we can.
And can you see the screen?
Yeah, we can. Thank you.
Okay, great. Thank you so much, Danny, for the kind introduction. I am delighted to be here. So I suppose I'll get right into it. I am going to talk about the topic I was given was extremely preterm neonates with PDA should be considered for pharmacological or surgical treatment. And I recognize that this is a highly controversial topic that has been the subject of debate for the last 50 years, really, in neonatal research. But really, in a nutshell, a cause and effect relationship between PDA and important morbidities, as you know, has not been definitively established. And RCTs of prophylactic and early treatments has failed to demonstrate a reduction in important morbidities and long-term outcome. And that's sort of been indisputable, really. So why am I here talking to you about treating some of the PDAs? Well, unfortunately, because of all of this evidence, the pendulum keeps swinging from treating everybody to treating no one. But even the most kind of diehard fans against PDA treatments do acknowledge that some infants may benefit from ductal closure. But the key really is identifying which of those infants actually would benefit from ductal closure and shunt elimination. And unfortunately, we as a kind of group of neonatologists have not really been, I think, doing it properly. And I would start by showing you a quote from Albert Einstein saying that if I had an hour to solve a problem and my life depended on the solution, I would spend the first 55 minutes determining the proper question to ask. For once I know the proper question, I could solve the problem in less than 5 minutes. And therein lies the problem, I think, with PDA research done to date, is that we haven't been really asking the proper question. We haven't been identifying the correct babies that most likely would benefit from treatment. We don't know who the high-risk infants are, and we do not know how to identify hemodynamically significant ducts. Once we identify those, or if we identify those, when is the ideal time to treat them? We cannot agree on that either. And really, we have never truly tested the consequences of non-treatment and prolonged exposure to PDA shunting in an experimental setting. And that's because of the high rate of treatment failure in the intervention arm, usually in a lot of these trials, and the high rate of open label treatment in the placebo arm. Kurt Duwall did a very lovely systematic review a few years ago, demonstrating the heterogeneity of the definition of what a PDA means in 67 randomized controlled trial. And as you can see, there is no consensus, nor is there agreement on what constitutes a hemodynamically significant PDA. In fact, in 25% of those studies, the diagnosis of how or how a diagnosis was established was not even mentioned. And when they do mention a definition of a HSPDA, it's very variable from study to study. So really, we can't truly say that we actually have honed down a diagnosis of hemodynamic significance. And why am I emphasizing this? I'm going to show you the kind of, I suppose, the issue with all the trials to date, and I'm going to use one trial to exemplify that. So this study that was published in Pediatrics 2 years ago hypothesized that early elimination of the PDA shunt, and I emphasize elimination of a PDA shunt with ibuprofen, may improve long-term outcomes. And I just want to sort of highlight a few things that I find an issue with. They allowed open label treatment in the control arm for pre-specified criteria. They also had a cohort of babies that were not randomized, but were labeled as a reference group, deeming them low risk for PDA-related morbidities. And as you can see from the trial in the results, that the rate of survival without cerebral palsy was 71% in the intervention arm, 71% in the placebo arm, and 76% in the reference group. So when you have a reference group that has the same outcome in babies that are deemed to be high risk, you really should question the method of selecting infants that were randomized. So I think how we select patients has been a problem in all those trials. And all the systematic reviews to date, I'm not surprised that they show that there is no difference in the intervention versus the control arm, because they have selected the wrong population and they did not actually select babies most likely to benefit from treatment. The second problem is the high rate of open label treatment in the placebo arm. So couple that with the fact that our intervention doesn't work in a significant number of babies, and the fact that the placebo arm has open label treatment, and the fact that we have poor patient selection, you wouldn't be surprised then when none of these studies have actually shown any difference in important outcomes. So, hot off the press this morning, came the expectant management versus early ibuprofen treatment for PDA done by Willem de Boot and his group from the Netherlands. And what they did in the study was that they selected babies using ductal diameter and randomized them to early ibuprofen treatment versus expectant management. And what they actually showed in them, they had a composite primary outcome of necrotizing enterocolitis, moderate severe BPD, or death. And what they have shown is that the incidence of the composite outcome was higher in the treatment group compared to the expectant management group. And that was driven by a higher rate of BPD in the treatment arm. Now, my concern with the study is that it will be interpreted as treating a PDA is harmful, therefore we should leave all PDAs alone. And I've already seen murmurs on Twitter and other social media outlets alluding to that. However, when you actually dig deep into the study and see, there are issues with that interpretation. And in fairness to the authors, they did not conclude that. And I'll show you what they concluded in a minute. The study was underpowered, recruiting only half of the original target group. There was no data on whether ibuprofen actually resulted in shunt elimination, so we don't know whether ibuprofen treatment worked in the intervention arm. The babies in the control arm had no PDA monitoring, so we do not know if these babies had a PDA that spontaneously closed, or these babies were actually exposed to chronic shunting. There was also a relatively high rate of paracetamol use in both arms for pain relief. And we all know that paracetamol now does cause ductal restriction. So about a quarter of the babies in the control arm were exposed to paracetamol in the study. And I'm going to show you soon enough, hopefully, that selecting babies based on ductal diameter is no better than flipping a coin. And many babies with a ductal diameter greater than 1.5, which was their entry criteria, actually do not need treatment and will end up spontaneously closing their duct. The other interesting thing that sort of links in with my issue with patient selection, the median gestation of the infants in the study was 26 weeks, yet the rate of chronic lung disease in some of the groups were as low as 30%. So to me, this is a group with a relatively low incidence of some of those primary outcomes, indicating that they are not the right group that would most likely benefit from ductal treatment. The authors acknowledge that. They say that the results of the trial should not be interpreted to suggest that there is no causal relationship between PD and neonatal morbidity in extremely preterm infants. And they say pathophysiologically, a high transductal left to right shunt volume with subsequent pulmonary hyperperfusion and pulmonary hyperperfusion and systemic hypoperfusion may indeed have adverse consequences. And there is evidence suggesting that prolonged shunt exposure is associated with the development of BPD. And they quote one of our studies when they make that assertion. And they kind of senior author assures me that there's more in-depth post hoc analysis to come to address some of these issues I highlight in the blue boxes, which I actually very much welcome. So, unfortunately, we keep repeating the same mistakes, and Albert Einstein defines insanity as doing the same thing over and over again, expecting different results. And I'm going to show you hypothetically what happens when you have poor patient selection in these ductal trials. So when you select all comers based on PDA diameter, which is really no good in selecting high-risk infants likely to benefit from PDA closure, and you have a hypothetical baseline risk for outcome of 50%, you're going to have a mishmash of babies in the intervention arm, some of whom will benefit from ductal closure, some of whom ductal closure may be inconsequential, some of whom ductal closure may be harmful, such as the case that was presented in the RCT I showed you published in the NGM today, and some of whom the intervention will not work. And in the control arm, the same thing happens as well. Some may benefit from non-intervention, and some may be harmed from non-intervention, and others, non-intervention may be inconsequential. The outcomes of these subgroups are usually mishmashed together, and you end up with an overall outcome that is no different between the intervention and the control arm, leading us to the erroneous conclusion that PDA closure in carefully selected high-risk infants that results in shunt elimination does not end up improving outcomes in these babies. And I don't think that that is true. I don't think that we have demonstrated that yet in any of the trials to date. What we need to do is better selection, have a targeted population, thereby they are more likely to benefit from the intervention and be harmed by non-intervention. And only then may we actually show meaningful differences in important outcomes to us. So why has it been really difficult to select the high-risk babies? Well, I think it's because of the fact that capturing the concept of hemodynamic significance is not that easy. It is not dependent on ductal diameter alone. We actually need to be able to accurately measure or assess shunt volume to highlight the level of pulmonary overcirculation and systemic hyperperfusion. We need accurate quantification of shunt volume, which unfortunately may be lacking to date. And we need to get better surrogate markers for systemic steel and pulmonary blood flow. We also need to integrate heart function and how the heart adapts to the increased preload as a consequence of pulmonary overcirculation and how that might impact hemodynamic significance. We also need to take into consideration the gestational status and other important clinical parameters that may modify the effect of prolonged shunting. So as you can see, none of the studies unfortunately have done that to date. And the concept of hemodynamic significance is complex interaction between several intrinsic and extrinsic factors, making its quantification a challenge. Shunt volume is not about ductal diameter. And Poiseuille's law dictates that at a constant driving pressure, the flow rate of the liquid through a tube is directly proportional to the fourth power of the radius of the tube and inversely proportional to the length and the viscosity of the tube. In other words, yes, the diameter, the bigger the diameter is, the more flow you get across it, but that is not the only determinant of flow across a tube. You have to take into account resistance, the pressure gradient, the length of the vessel, and the viscosity of the blood or the fluid flowing through that vessel. And if you think about it in the clinical context of a preterm baby, all of these parameters, vessel length, pressure gradient, blood viscosity, the diameter of the vessel, all change constantly over the first few days following birth. So a single time point of measurement using one single measure as a surrogate marker of shunt volume will not help you in picking the right babies. What about heart function? We know that preterm infants have reduced diastolic filling and they have a stiff myocardium with disorganized fibers, a lot of fibrosis, and dispersed mitochondria. The end result is that it cannot handle increased preload because of the diastolic dysfunction. Well, is that clinically relevant? Yes, it is. We have demonstrated that infants more likely to remain ventilated over the first few days of life have worse diastolic function measurements using echocardiography compared to babies on CPAP when you adjust for a lot of important confounders that you can see in the blue box here. And again, pulmonary hemorrhage is more likely to happen in infants that have worse diastolic function. So here is an example of a mechanistic explanation as to why some infants develop pulmonary hemorrhage and others don't. I think it's all down to diastolic dysfunction in these babies. Why is that relevant? I'll tell you now in a second. Important clinical considerations. All of these things that you see in front of you could act as effect modifiers that need to be taken into consideration. So hemodynamic significance is an amalgamation of shunt volume, heart adaptation, other clinical parameters that give you this kind of definition. We haven't really related that concept to important clinical outcomes yet. We haven't established whether there's a causal link between this concept of hemodynamic significance and important outcomes. We haven't determined when we should determine significance, and we haven't actually examined if we can modify the course of this significance, do we end up with better outcomes? Well, our group, a big collaboration with also Professor Patrick McNamara and other centers around North America and Europe, tried to begin to answer this question. We developed a PDA severity score that incorporates all of these concepts that I've described to you to try and capture the concept of hemodynamic significance. We did a lot of echocardiography measurements and looked at a lot of clinical parameters, and we found that those 5 measurements, gestation, PDA diameter, LVO, left ventricular output, PDA velocity, the maximum PDA velocity in systole, and LV diastolic function, incorporated together, can result in a score that is highly predictive of important PDA-related morbidities, such as chronic lung disease and death. If you look at PDA diameter, it is the least predictive out of the other parameters in the model when looked at in isolation. The score ranges from about 0 to 13, 14, and if babies have a score less than 5, they are highly unlikely to develop chronic lung disease or death. However, if they score 5 or greater, then they have over a 90% chance of developing chronic lung disease or death in the setting of a PDA. So here you have a score that selects babies that are likely to develop the morbidities that we're trying to reduce, such as chronic lung disease or death. When we compare this score, which is in solid black, to PDA diameter alone, which is in the dotted gray line, you could see that the PDA diameter alone is no better than flipping a coin in patient selection. So any future study that wants to randomize babies for a PDA treatment trial using PDA diameter alone might as well just flip a coin. It's a lot cheaper for you guys to do. We did an RCT ourselves, looking at the feasibility of recruiting babies into a study based on this PDA severity score alone. And what we demonstrated that it was feasible. We were able to reduce the rate of open label treatment in the placebo arm, but we demonstrated a very low rate of PDA closure in the intervention group and showed no difference in our primary outcome, which was chronic lung disease or death. And before I go on for the rest of the study, I just want to show you a trigger warning. The following slides will contain a post hoc analysis that some viewers may find offensive, so viewer discretion is advised. Okay, so we examined our data further. We wanted to see whether within the treated group, do the babies that successfully closed their duct following treatment, did they have better outcomes than those that kept their duct open despite treatment and those in placebo? And you could see that 17 babies out of the 30 had a successful intervention, meaning that when we gave them ibuprofen in the intervention arm, they actually closed their duct and eliminated their shunt. But 13 failed the intervention, and they were slightly smaller and slightly lower birth weight. So when we looked at the 73 babies in the study, 60 of whom had a high risk score and were randomized, and 13 had a low risk score and were not randomized but were followed to discharge. Out of the randomized babies, 30 received the intervention and 30 had placebo. And you can see here, out of the 30 that received the intervention, 17 successfully closed and had a median day of ductal exposure of 2, whereas the 13 that remained open had a median ductal exposure of 24 days. The placebo group, fortunately, kept their duct open. This is telling you that if you score high without intervention, you will keep your duct open. So this is further validation that a score can select babies unlikely to close their duct and likely to develop morbidities related to the duct. Ones that scored low spontaneously closed. The majority of them spontaneously closed their duct with a median exposure day of 2. And you can see here, when you examine the outcomes based on the subgroup analysis, you could see that we are able to modify the baseline risk in babies if we successfully treat their duct. However, as a caution, if you give a baby ibuprofen and do not close their duct, then their rate of adverse outcomes goes up. And I think this explains the finding demonstrated in Willem's study, showing that babies in the intervention arm had a higher rate of chronic lung disease than babies in the control non-intervention arm. So if you give ibuprofen and you don't achieve ductal closure, you're exposing the baby to the adverse effects of that medication without the beneficial effect. And that's something that studies have not looked at so far. Look at the median PDA diameter in the low risk groups, 2.8. So a lot of these babies, all of these babies would have been included in all the previous studies where they did not need to be included. So again, patient selection based on ductal diameter alone should be abandoned. Future studies should focus on selecting high-risk infants. They should devise treatments that ensure shunt elimination, not just be satisfied with treating the duct without actually achieving ductal closure. The control arm should strive to maintain ductal patency so that we can truly examine the effect of chronic ductal exposure versus early shunt elimination. So to conclude, the current approach to trials of PDA treatment has failed to identify an ideal way to approach PDA treatment. Trials to date have asked the wrong question and have looked for the wrong answer. And we need a radical change in the approach to such trials. And I would conclude by saying that it is now unethical to continue randomizing infants in PDA trials based on PDA diameter alone. Thank you for your time.
Thank you very much, Dr. El-Khuffash. Definitely some food for thought there. We're all interested to see also the other side, and I'm going to ask and welcome Dr. Benitz with his side, which is that you may not wish to routinely treat babies for PDA. Hand it over to you, Dr. Benitz.
Okay, if I can make this there we go. Is everybody able to hear me?
Yeah, we can see and hear you.
Very good. So I have nothing to disclose. And I'd like to just begin with a brief review of 5 recent trials, at least 2 of which have been already discussed. And I'd like to preface my comments by noting the extent to which Dr. El-Khuffash and I are in agreement about where the future lies for these investigations. He concluded with a comment that he thinks it's unethical to continue to enroll babies in trials where the sole criteria or the major criteria is ductal diameter. I would echo that by saying I think that it's unethical to continue to treat babies based on the criteria that have been utilized in prior trials, which clearly, as he points out, have failed to identify the appropriate high-risk group. So let me provide the background that supports the argument that you've just heard, that we have yet to identify the appropriate population of babies who might qualify for treatment for persistent PDA. These 5 trials published over the last year and a half or so, I won't go through in detail, but I will note that they're the most recent additions to the continually growing collection of randomized controlled trials of PDA treatment in preterm infants. These 5 trials, like previous ones, have shown no difference between treatments and controls, no change in survival without cerebral palsy, that expectant management is non-inferior to early treatment, and non-inferior to early treatment with respect to the combined outcome of death, NEC, or moderate or severe BPD. The Ductus trial, which, as you just heard, just came out in the New England Journal this Thursday morning. And the baby Oscar trial showed no reduction in death or moderate BPD. When we add these trials into the ones previously described in the meta-analyses that we reported most recently, updated in 2020, along with my partner, Mira Sankar, we are now up to 67 randomized controlled trials that include 57 subjects, And we can see in those trials that there is good efficacy for reduction in the rate of ductal patency with an odds ratio of about 0.3. But with the exception of intraventricular hemorrhage and intraventricular hemorrhage greater than grade 2, based largely on data which are now growing rather long in the tooth from back in the 1980s, is no other significant impact on outcome for these 8,000 babies enrolled in these trials with respect to the important outcomes, particularly of death, BPD, death or BPD, oxygen use, or neurodevelopmental outcome, or death or neurodevelopmental outcome. These results don't differ depending on how these trials are sliced up according to the agent used, the indication for treatment, the route of administration of the drug, age at treatment across the range examined at least, the use of rescue treatment. I'll show you a little bit of data about that, the year of the trial, or the gestational age of the babies. So from this, we can conclude that there is no evidence to support the use of the agents tried for the criteria for which they have been applied. Now, one of the arguments that we often hear is that if only the agents and the interventions that we tried were more effective, we would see more effect, beneficial effect on the important outcomes of death or oxygen use at 32 weeks, or the combination of those two. If that were the case, these relationships between the odds ratios for persistent PDA and the odds ratios for those outcomes should have a slope that is different than 0, such that the lower the odds ratio for persistent PDA, the lower the odds ratio for the outcome in question should be. And we see that when we look at these maps relating the outcomes, that there is no impact of higher odds ratios for PDA closure or higher probability of PDA closure with a lower probability of reduction in the outcomes of interest. If the PDA closure mediated the avoidance of those outcomes, there should be significant correlations. And the fact that we don't see them means that it is unlikely that those outcomes are going to be significantly altered by more effective treatments. It's important, however, to remember the qualification that this applies to the populations and the indications for which treatment has been studied. So to summarize the evidence, as Dr. EL-Khuffash just showed us, the evidence that treatment to close patent ductus arteriosus is beneficial in preterm infants consists of that shown on this slide. It is simply non-existent. But I would argue that the case is actually worse than this. It's not that we don't know whether benefit or not. We actually have a great deal of evidence, and that evidence is that there is, in fact, no benefit in the populations for the indications and with respect to the outcomes that have been studied. And I think that this last sentence is really the motivating force behind the importance of pursuing the kinds of well-selected, carefully designed, and meticulously executed trials that Dr. EL-Khuffash is. So just a brief aside here, I'd like to comment a little bit on why post hoc and observational studies seem to indicate that these treatments are beneficial. And the point here is that those apparent benefits that are observed in studies that are not randomized trials are illusory. If we have a hypothetical scenario where we have a population of babies, 90% of the population constituting group 1 and 10% group 2, we have two conditions that are not caused, A and B. In group 1, the prevalence of condition A is 100% at birth. And of course, this is the circumstance with PDA, but it declines with a half-life arbitrarily chosen here of 2. And another condition, group B, that has a prevalence of 10%, invariant with age and is dependent of condition A. Notice that these two conditions are fellow travelers, but not causally related. In group 2, the prevalence of both conditions is 100% and also invariant with age. And you can't tell these groups apart, at least until the babies are 30 days old. If you have that situation, you'll see that there's a steady decline with postnatal age in the occurrence of babies who have condition A only, an increase in the proportion who have B only, and a reduction in the portion that have both conditions. If we do traditional kinds of correlation analyses, we see that condition A is very strongly associated with condition B. The prevalence of 32% if condition A is present and 10% if not. And the odds ratio here is highly statistically significant. So these are definitely associated conditions, but as noted in the preamble to this, they're not at all causally related. From this, we get many of the consequences that we see in observational studies. Spontaneous resolution of creates the apparent efficacy, even for ineffective treatments with decreases with age. Resolution creates the illusion that earlier treatment, whether it actually affects condition A or not, would reduce the risk of condition B. And logistic regression analysis would show that the odds of condition B increased by 38%, additional day of exposure to condition A. Those observations should give us great cause in interpreting observational and retrospective analyses, and should give us great caution about the sort of post hoc analyses that you just heard described for purposes other than suggesting improvements in design for future trials to avoid potential errors. Here's a summary of data relating the PDA exposure and risk for death of bronchopulmonary dysplasia. On the left, related to the severity of the hemodynamic consequences of exposure to PDA, showing in the 3 right-hand columns babies who had greater than 7 days of exposure to severity level E2, E3, or E4 by echocardiographic criteria as described by McNamara and others, showing that if there is a PDA for greater than 7 days, there's a definite increase, but the hemodynamic manifestations of that are not statistically associated with increased risk. So the presence is, but the apparent severity is not. In data from Orlando, on the right-hand panel, we can see that exposure to a moderate to large PDA, even for less than a week, is associated with an increase in the risk of death or BPD, but further prolongation of the exposure to 1 to 2 weeks or greater than 2 weeks is not associated with a statistically significant further increase of those outcomes. These data point out that there's a lack of a dose-response relationship between PDA duration or severity and the probability of these outcomes. And in the absence of a dose-response relationship, a causal relationship should be viewed with skepticism. Here's data from 2 recent papers by Dr. Kleiman, showing first in data from his own center at UCSF that the rate of death or BPD is associated with the duration of exposure to a moderate to large PDA, that risk duration exposure greater than 7 days. But after that 7-day threshold is achieved, there is no further increase in the risk with even more prolonged exposure. In the right-hand panel, that data is broken out to separate babies who were intubated for greater than or equal to 10 days, shown in the orange, and babies who were not intubated for more than 10 days, shown in the gray. And they show, again, that there is a threshold relationship For the babies that were exposed to a moderate to large PDA for 11 days or more, there is an increased risk, but longer durations of exposure do not further increase that risk. And for babies who are intubated for a short period of time, there is no relationship between the risk of grade 2 to 3 BPD and duration of exposure to PDA. So here's a summary of the evidence. As noted in the talk you just heard from Dr. EL-Khuffash, numerous randomized trials of treatments to close the PDA in preterm infants have demonstrated absence of benefits. If there are babies who will benefit from intervention to close the PDA, they must constitute a small minority of those who come under our care and a modest minority of those who have previously been randomized into our controlled trials. If we were to continue to apply treatments to close persistent PDA in preterm infants, we must identify babies who stand to benefit, who, when, and why, specify what that benefit might be, and that's one of the deficiencies of the prior trials, which Dr. Khuffash did not emphasize, but I think is implicit in his comments. And we must demonstrate that there is realization of that benefit in randomized trials. And hopefully you can all see the similarities recommendations to those were just made. The speaker on the counter position. And with that, I will end.
Thank you, Dr. Benitz. It's so interesting that Dr. Benitz and Dr. EL-Khuffash arrived at the same conclusion, but took polar opposites approach. But it's time for the counterpoint, and Dr. EL-Khuffash, I invite you to give your counterpoint, and you have approximately 5 minutes.
I don't know what to counter. I'm actually shocked that we arrived at the same conclusion. But I mean, I suppose what's encouraging is I suppose our agreement that we should stop doing what's been done before, and that we should at least look at a different way of looking at the problem. I think we both agree that there is a select group of babies that may potentially benefit from PDA treatment. We have not identified that cohort yet, although I feel that we are sort of a little bit closer to that with more kind of, I suppose, sophisticated scoring systems. And I suppose the point I would make as well that may kind of explain the kind of lack of benefit is, you know, the medications we use are not clean medications. They have significant side effects. And I actually am increasingly realizing that if there is a potential benefit to closing the duct using non-steroidal anti-inflammatory medication, you're only going to achieve that benefit if you actually achieve ductal closure, because I think you may potentially be gleaning the benefit of eliminating the shunt and offsetting the side effects. Everybody's going to get the side effects, but only a small number of babies end up with the potential benefit of those medications. And I think that in part explains why we haven't really demonstrated an improvement in high-risk babies. I think we still sort of don't realize or don't appreciate the anti-angiogenic effects of non-steroidal anti-inflammatory drugs that may actually independently contribute to BPD. And Willem's trial this morning gives you food for thought for that. I mean, it demonstrated that treatment with ibuprofen increases the risk of chronic lung disease in these babies. But what we don't know from the study yet is whether the treatment of ibuprofen was done in the right babies and whether it actually resulted in achieving ductal closure. And I think therein lies the problem with the majority of our trials that we have done to date, is that we do not actually have those answers. And couple that with the high rate of open label treatment in the placebo arm in a lot of the trials, where you actually end up with two arms of very similar babies. And I'm not surprised that we haven't really demonstrated differences using that same trial design. And unfortunately, the Oscar trial, which has been presented in several meetings now, suffers from the same issue. They use ductal diameter as one of the primary criterion for entry into the study. And there was a rate of open label treatment of around 45% in the control arm. So again, we're repeating the same mistakes over and over again, and we really need to take a step back. And as Dr. Benitz said, do very careful studies done meticulously, selecting the high-risk babies, even as a first step to try and prove the concept that if we achieve ductal closure in a select group of high-risk babies, then you may modify the risk. And only then you can then transfer that into a larger study. I'll stop talking now for now.
Thank you, Dr. El-Khuffash. Dr. Benitz, I invite you for your rebuttal. Although I think you're muted.
I share Afif's surprise at how much we are in agreement. My first comment would be that just as a first principle, I think that we all agree that treatments that don't work shouldn't be used. And I think we've amply demonstrated that these treatments, the nonsteroidal anti-inflammatories, in aggregate don't work for the group of babies for whom applied. And we need to stop doing this. Einstein was right. Keeping on with using this treatment and doing trials of this treatment in the populations that we've tried it before really has to be abandoned. It's insane. So treatments that don't work shouldn't be used. And we know that these treatments don't work in the populations and for the indications that we've been using them for. It's time for a change. The second comment that I would make is that conditions that are not diseases don't need to be treated. And I think all of us would agree that the presence of a patent ductus arteriosus without any additional information at hand at 6 hours of age is a very normal circumstance, is a condition in that baby, but it doesn't require treatment. The puzzle comes in trying to figure out where between that nearly essentially universal condition and the 6-week-old baby who's got a massive left to right shunt, cardiomegaly, left ventricular dysfunction, pulmonary edema, ongoing respiratory support requirements. That condition has transitioned from being a condition to being a disease. And that's the challenge that has been so elegantly outlined by Dr. El-Khuffash. We really need better tools for spotting the babies who really might stand to benefit, and then use of very targeted and hopefully more effective therapies, perhaps like placement of the piccolo occluder. And the pivotal trial is in progress now and is designed to try to address that question. One of the limitations of the pivotal trial is that it requires failure of nonsteroidal treatment to close the ductus as an indicator of high risk. And that may actually focus on the very high risk population of infants who fail treatment that Afif pointed out for us on one of his later slides. So I think that it's really critical for us to focus on identifying these very high-risk babies, the ones who are at the extremes of prematurity, perhaps those less than 24 weeks, the ones with extremely large and consequential ductal shunts. We need better tools for measuring and identifying those conditions. I would point out that the studies that I reviewed in the meta-analyses, essentially all the latest date of enrollment in the controlled group was at 21 days. So there's no or in the treatment group was at 21 days. So there's no data really to guide us about management beyond that postnatal age. We need studies of more effective treatments. The argument, however, that treatment lack of efficacy for closing the ductus might somehow translate into an argument for using that treatment seems very puzzling to me. Doesn't work to achieve the primary mediator of potential benefit, then it doesn't work. And I think that's another argument actually for stopping the use of those medications. There are a number of unassessed or incompletely addressed outcomes that we need to evaluate, one of which is immediate respiratory improvement in respiratory function, development of late pulmonary hypertension or pulmonary vein stenosis, myocardial dysfunction or remodeling, which may be a chronic phenomenon, and chronic renal injury, and as the recent studies have begun to adopt neurodevelopment. So I think there are plenty of areas for exploration here, and I would argue that the ethical thing to do with the baby who might benefit from treatment for the PDA is to enroll them in a well-designed randomized trial and to abandon the practice of blind open treatment completely.
Thank you, Dr. Benitz, Dr. EL-Khuffash. We've all learned, I think, about how to refocus and look at some of the specific aspects of the trials to date, and it's oriented us to take a more careful look at the options that we have for clinical management. I don't think we certainly haven't solved anything. There's no Nobel Prize that's to be won after the talks today, but I think it frames it in a way that hopefully is helpful for our trainees and for our audience. And again, I recognize you guys kind of started at the same point, went opposite ways around the world, and ended up at the same conclusion. I think we will have